Thank you very much. An interesting sort of negative title, and I will address it, but put a little bit of other stuff in as well. Probably the best, biggest, and most meticulously done study is this meta-analysis, Gonzalez, and it's 2013. It's about 3,000 patients. It's the best 25 observational studies and comes up with the things which we all recognize. That non-solitary metastasis, there is a 2-3 effect, but basically it's solitary versus multiple. And in this whole series, 63% were solitary. That takes some teasing out of the paper, actually. It's not easy to find. Hazard ratio, 2.04. Elevated CAA, and there's no data in it about it. It's whether they measured it or not. It's extremely vague. But they managed to come up with a hazard ratio, which is nearly 2. Again, well known. And a short interval between the primary resection and the metastectomy. And the medians, very difficult to pull medians, but different reports are 19 to 39. So somewhere around 2 to 2.5 years intervals. Now, what they summarized is at the bottom here, overall 5-year survival was 42%. Again, you have to actually tot up all the numbers in the tables to arrive at that, but that's about the number which has come up over and over again. 40%, 42% 5-year survival. But they say the benefit attributable to surgery is neither immediate nor irrefutable. And in the absence of evidence-based data, there is no consensus as to how to select these patients who may benefit the most. So they assume benefit, but which ones will benefit the most? But really a very carefully done study which tells us things we sort of knew already, but is hard to interpret. So hazard ratios and relative risk, it's all relative. And these are predictors between patients, not between treatments. Ratios tell us less than we knew way back from 1997 from the lung metastasis register. And the problem is it's actually very difficult to convert hazard ratios into a decision about whether we should do it or not, and how do we put it to an individual, what that means. It remains very hard to interpret. So going back a bit, this is one of the, probably the biggest follow-up study, and it's combined Duke, Memorial Sloan Kettering, nearly 400 patients. It's a database analysis, so very old-fashioned, unsophisticated way of interpreting data. One of their conclusions, and it's there in the abstract, is patients with 3 or more metastases and an interval of less than 1 year, the 5-year survival is 0 out of 44. Now, there are confidence limits around 0, but it's fewer than 1 in 1,000. It's 0.08. So they quite firmly say patients with these features should not have an operation. So there's one answer to the question put to me. But people haven't really paid a lot of attention to the numbers limitation. You probably know this paper from Raleigh, in which he is taking out an average of 10 mets per patient. He doesn't give us a median, but it's probably a bit lower than that, because you'll see up above, one patient, he took out 124. And the question I would have with him is, very good. You absolutely sure there wasn't a 125th there somewhere? This is extraordinary. And to me, that looks like a surgeon who never says no to metastectomy. One of the things that brings you under pressure, though, is the liver surgeons. And they are utterly committed and on a mission to expand this practice. This is a big NHS-based analysis from a group of liver surgeons written by Eva Morris. And they point to this as the evidence of the benefit. So these are patients who've had liver resections, and these are different cancer stages, colorectal cancer stages. Now these, of course, do look like cancer curves. That looks nothing like a cancer curve. It's really very strange to put that on the same slide with the others. This is a slide which is produced by selection of the best cases, repeat selection, watching them over time, continued treatment, so they get chemotherapy during a period of 3 or 6 months before the liver resection has done. And I've been to all of their meetings for 3 years in a row now in Barcelona. There's a big colorectal metastases meeting. And they talk of the test of time. Now, of course, that produces a group of patients who are very unlikely to die soon. And what this slide shows, it's exactly the same data. And if you have groups of 50 and 70, or 200 and 230, or 1,000 and 1,200, it is reasonable to normalize them to percentages and put them on the same graph. But here we have a group of patients in the 100,000 range of patients who've had colorectal cancer. And then down here, about 3,000 patients. So you really can't pull them and normalize them on as single percentages. It just falls apart. And what you can see is that the plateau is still there. There it is. The disparity in the sizes of the groups being compared is enormous. And there is a very high degree of selection to get this very few patients for liver resection. And there is the plateau. So what they have done is found a group of patients who are very, very unlikely to die. They're good doctors and good teams with oncologists, and they can pick the winners. So the plateau that I showed you is not a reflection of the effect of surgery. And actually, that shouldn't surprise you, because the reason for doing metastectomy is to get some long-term survivors. You're not doing it urgently because people are going to die of their metastases within the next year or two. That's not what happens. And indeed, lung metastases are almost never a contributor to terminal events. Patients don't die of their lung metastases. It's extremely rare. Well, there is a randomized trial, and this is now with the liver, and this is radiofrequency ablation. The clock trial, which they're very proud of, and they worked extremely hard, and all credit to them. But there is a problem. We know that the number of metastases influences by twofold your risk of dying. And here the ablation arm, in green, is very different to those in the control arm. So there's more than double the number of solitary metastases, and about a third fewer of the multiple metastases. With a hazard ratio of over 2, that probably accounts for all of the very small difference in the patients, which is only there after 5 years. But it is a late result, and it might be patients who are truly cured of their liver metastases by radiofrequency ablation, but it's very suspect. Now, in the PulMiCC trial, we ensured balance. This is a good and proper thing to do, to not go to the process of randomizing a trial and then end up with unbalanced groups. How did it happen? Just bad luck? The randomization failed, but somewhere along the line, it messed up the clock trial. Well, the light gray things, they all match. This is arm 1 and arm 2 of PulMiCC. And they're all similar, the age and everything else. Here are the 3 we've mentioned, the interval, the CEA, and the numbers. And you see, they're very well matched. So we should be able to trust a result from PulMiCC in a way we can't trust results from big follow-up studies, however big, meta-analysis, however complex, and other studies where the whole process of randomization has failed. The groups were not similar. Now, we do face yet another problem. There are 512 patients in a registered cohort, and we have the data, and we will be working on that and following them up and studying what's happened to them. But 82% of eligible patients did not get into the randomized study. We went to 3 of the biggest recruiters and Liverpool, Bristol, and Sheffield, and asked them to tell us about it. And what we found was there were 41 randomizable patients who preferred not to be randomized but to make their own choice. Nearly half of them chose to not have an operation. So they demonstrated equipoise. As a group, they could go one way or the other in about equal numbers. Of 78 randomizable patients where the MDT overrode eligibility for randomization, 77 of 78 were given an operation. This was in spite of these MDTs declaring equipoise. They didn't have any equipoise. Look at it. Extraordinary thing. I mean, quite a remarkable finding. Then you'll have seen this paper, which opens with surgery for pulmonary metastases is a pillar of modern thoracic surgery. I put this in quotes because this isn't me saying that. In the course of writing our letters to the editor, Professor Dame Leslie Fallowfield, international guru of quality of life studies and an outstanding researcher, Fergus Macbeth, oncologist, Cochrane Nice, and a clinical trial researcher, a loyal worker with us, say some thoracic surgeons actively sought to prejudice potential trialists through an inflammatory editorial. In this, they use the parachute analogy, which you will know well, and it does not apply to metastectomy, by the way. There are lots of things it does apply to, but it's not that. That there is no need for controlled data because surgery for pulmonary metastases is a pillar of modern thoracic surgery. If they think that is representative of thoracic surgeons, they must think we're a bunch of jokers because you just cannot, in the face of all the things I've shown you, make that claim. It is true, there's an awful lot done, and it does represent quite a lot of work, but are the pillars on sand? So here is PulMiCC in summary, and I've chosen to start by showing you this. These are the individual patients, 33 in one group and 32 in the other group, and these are the ones who are alive at 5 years. Now, there are some other adjustments to be made because there are censored patients who haven't been there for 5 years, but as far as this depiction is concerned, they are the randomized patients. The color encoding is curious, you will think, and it goes from darkish red to brightish green through middle zones, and basically it's putting together the interval, the number of metastases, the CEA, and a bunch of other things to create a gradation. And you can see that the color spectrum is similar in the two groups. The two very green ones, there was one patient in each group who did not have metastases. One in each group, and they both, rather good to see that they were both alive 5 years later. Well, it's convenient for me as a trialist because it makes it an easier story. And there was no patient in the control group, and this is intention to treat, who had a metastectomy. And there were the treatments in the two groups. A few patients had ablations and a few patients with radiotherapy, and quite a number of patients had chemotherapy, but they were similar between the two groups, which was, again, very fortunate. Now, and you'll see the figures here. There is a difference. That 30% comes not from this, but from the Kaplan-Meier. But look, you can see this is the vulnerability of small numbers, and that's why I put it to show you. It would only take one patient to swap size to turn the whole thing one way or the other. Extremely vulnerable. And that's why having 65 patients was very disappointing out of that number. And the frustrating thing now is I'm trying to get it published because I think there are important lessons in it. I say, this is a small study. It's all over the paper. It's in the covering letter. There are only 65 patients. Go to the editor. They come back. There's only 65 patients. Thank you. I told you that, and we all could have saved you a lot of work and us a month's delay in getting an answer to something you knew already. But here is the point. Here, that 30%, in the control group, there is a 5-year survival of 30%. The huge confidence limits, of course. But a fair number of patients survive. The notion about metastasis, liver and lung, has always been 5-year survival approaches 0. And if you push people and say, well, it's under 5%. But you see here, this narrows the gap enormously. And even if inconclusive, that's not going to drop below 5%. And this figure is very comparable, absolutely comparable with that huge meta-analysis. There it is. The trial reflects real world. That's what the Kaplan-Meier looks like, and I'm not going to leave it long so that you don't take pictures of it, because it's not yet published. But you've seen it, and you can see the Kaplan-Meier is what the rigorous trialist will want, and the hazard ratio, but it's not significant. But the blocks show you that it's not significant. One chap changing sides and it will go. Now, there are reasons to think that a no benefit from metastacectomy outcome is possible. There have been 2 meta-analyses of multiple RCTs looking at intensification of monitoring for the express purpose of picking up recurrence. If you pick up pelvic recurrence, you do benefit patients by earlier interventions, certainly in terms of their quality of life. But there is no hint anywhere in any of these papers that the increased number of metastacectomies that can be done influences survival. There is no or slightly impaired, no difference in survival or slightly impaired survival in those who were multiply screened. Why do we screen? And that's the key question. We'd all be better off not detecting the metastases if we cannot make a difference, but that's a hard thing to claw back on. So there is another whole area, and that is this big meta-analysis of advanced colorectal cancer treatments. And there have been many, many randomized controlled trials of all sorts of treatments, but there have been none of metastacectomy. Now, the possibility arises, so no randomized studies, of reverse causation. Because of better management, earlier detection, and so on, there are bigger windows of opportunity in which to do things. So there are more metastacectomies done. We've seen that. Well, better do something. But it could be that the association, if there is one, between more metastacectomies and longer survival is actually reverse causation. It's the longer survival gives you opportunities for more metastacectomies. So, some concluding thoughts. These patients are, without exception in this type of work, asymptomatic. If a patient has a symptomatic metastasis, you treat it on its merits. You treat the pain, or you treat whatever it is that you think you can help with. But metastacectomy done as a policy is in asymptomatic patients. As I told you, and I've said this over and over again, and nobody contradicts me, because I don't look after terminally ill colorectal cancer patients, but people who do say, yeah, that's a good point. Follow-up studies show 40% 5-year survival. This has been assumed to be a gain over 5%. But in PulMiCC, the 5-year survival was similar to reported results, but comparable, directly comparable, non-operated in patients, the survival was greater than assumed. So who should you not operate on with pulmonary metastases? Well, I think any time, unless you've got a good reason, you should not operate. And operations that really work, you operate on the worst cases. You don't select the best. So you don't operate for mild cataracts. You operate on the bad ones, because they're the people who need it most, and that's where you get your best turnaround in benefit for patients. You don't operate on mild osteoarthritic hips. You operate on the worst ones. And lung volume reduction surgery, not the really bad ones who are going to die, but the people whose lives are miserable and you can make them better again. That does not exist anywhere in practices of pulmonary metastacectomy. And we measured, in case you're wondering, psychological benefit, rigorously done by Leslie Fallowfield's team. And there's a small dip in quality of life as you would expect from the operated group, and then they pull off. Of course, the numbers are getting fewer. But there's no sign that there's any difference in anxiety attributable to the operation or between the groups. Now, of course, you will have occasional patients who are frantic to have something done. Please get this out of me. And that would be a reason to operate to remove a metastasis. But it would also be reasonable to say, look, this is not what's going to determine your survival. And when told that within the trial context, 46% of patients, nearly half, said, all right, then don't operate. Done.